Good afternoon, everyone. My name is Julia Liao, and I'm a Chief Deputy at Asian Health Services. And it's a great pleasure for me to welcome all of you to our panel discussion, Shaping the Future of Healthcare. We are thrilled to have all of you joining us virtually for this event. I'd like to take some time to thank the Korean American Community Foundation, the Asian Business League, Asia American Multi-Technology Association, Kaiser Permanente, Asian Pacific Alliance, and Blue Shield of California Asian Pacific Alliance. I'd also like to recognize Asian Health Services Business Leadership Council and PricewaterhouseCoopers for their support of this event. Tonight, we have a unique opportunity to hear from top leaders and experts about the latest innovation trends and opportunities to tackle the stark inequities that have been laid bare by the pandemic. As a nonprofit clinic that has served and advocated for medically underserved communities for over 4 decades, Asian Health Services has seen firsthand the deepened social, economic, and health disparities exacerbated by COVID. Our nearly 470 staff have been on the front lines caring for our most vulnerable in English and 14 Asian languages. From doctors to dentists to mental health counselors, we have kept our doors open during this crisis to serve 50,000 patients who otherwise would not have received healthcare because they don't speak the language, can't afford healthcare, or because of their immigration status. Because Asian Health Services is more than a clinic, working outside our clinical walls to catalyze positive change in our community, we have seen how COVID has presented opportunities for our nation's health system to not only catalyze, but exponentially accelerate healthcare technology that is transforming the way we deliver care. It's technology that we want to ensure can help our vulnerable children, families, and elders, as we believe we are only as strong as our most vulnerable. So thank you all for being here with us for this important dialogue. I'd now like to turn it over to our Chief Innovations Officer, Dr. George Lee, who will share how we have framed our panel discussion today.
Great, thanks, Julia. All right, well, welcome on behalf of Asian Health Services. I actually wanted to start by telling you a somewhat scary story that illustrates some of the challenges that we face. We had an 87-year-old Vietnamese-speaking patient who actually just became our patient about a month ago. And she had a regularly scheduled telehealth follow-up for chronic disease. And she happens to mention that she has chills and headaches for 3 days. So because of this, our provider has her come in for a face-to-face visit. She had a COVID test done, and then we sent her home actually with a pulse oximeter, which is a machine that's used to check the oxygen levels. And as you can probably guess, she tested positive for COVID. But unique at Asian Health Services, we actually regularly check up on our patients who test positive for COVID, just to make sure that they're doing okay. So on one of these checks, she tells her doctor that she's breathing okay, but she's confused about some of the numbers on the pulse ox machine. Okay, so one of them reads 73, and the other one says 105. So after thinking about it for a moment, the oxygen percentage can only go up to 100. So what that means is that the 105 has to be her heart rate, and that meant that her oxygen level was only 73%. So the doctor tells her, hey, call 911. She ends up going to the emergency room. But fortunately, she is, doing well currently with oxygen. But I wanted to tell you the story because I wanted to highlight the fact that with our most vulnerable patients, we need to be very proactive about their care. We gave this patient a pulse ox to take home. We called her every few days to make sure she was okay. We know that telehealth is a great innovation with huge potential, but our worry is that our most vulnerable patients will not benefit from these advances. So for example, number one, language. This patient spoke Vietnamese only. Are the health apps, patient portals, other communication tools being designed with the needs of the limited English speaking population in mind? Number two, digital and health literacy. This patient was 87 and couldn't figure out how to read the pulse ox. How can we overcome the issues of digital literacy? Or how can we overcome some of the barriers that seniors may face when they're dealing with things like hearing loss or vision impairment. And number 3, reimbursements. We can receive reimbursements for these telephone and televideo visits during the public health emergency. But if telehealth is really here to stay, and we all think it is, what mechanisms need to be in place in order to support it after the emergency, especially since many of our patients don't have the digital skills to use a specific video application. So it is with these challenges in mind that we've brought together this whole set of panelists, very esteemed folks. We know that there's been tremendous advances in technology and telehealth. What we want to do is to ensure that our most vulnerable patients will be able to benefit from these innovations. And as you might gather from my patient story, it's both critical and urgent. So I'd like now to introduce our special moderator for this evening's panel. Katherine Kohatsu is a principal at PwC's Advisory Health Industries practice. She specializes in the government program space, including Medicare, Medicaid, and dual eligibles. And she has more than 15 years of professional experience with her clients to capture billion-dollar growth opportunities. Please welcome Katherine Kohatsu.
Thank you, Dr. Lee. I am thrilled to be here moderating this exciting discussion this evening on the future of healthcare and emerging innovative solutions for underserved communities. We have with us tonight top leaders and experts in their field to give us their insights and perspectives on driving innovative healthcare solutions to our underserved populations, highlighting that case that you just mentioned. First, we have Dilip Parekh, the Chief Medical Informatics and Digital Health Officer at Alteus. He oversees the digital health products and services portfolio, as well as the strategy and execution to bring Alteus's digital health products and their clinical services to the market. Prior to joining Alteus, Dilip was a professor of surgery at the University of Southern California for 28 years. He held numerous clinical leadership positions at USC, where he was responsible for the strategy and execution of telemedicine and digital health initiatives across the health system. Dilip is also the founder of digital health company CarePlaces Inc. Second, Dr. Vik Bakhru is a practicing physician and Chief Operating Officer and Chief Medical Officer at Consejo Sano, a multicultural health technology platform dedicated to improving quality of care for vulnerable and underserved populations. As well, he is also the founder and chairman of the board of directors of the Foundation for International Medical Relief of Children. Diana Camacho is Kaiser Permanente's community benefits and national Medicaid business strategist. She leads the development and implementation of partnerships and investments to the healthcare safety net with the aid of advancing the health of underserved populations. Her work spans Kaiser Permanente's 8 regions and includes community benefit initiatives and investments and care delivery partnerships. Prior to Kaiser Permanente, Diana was the director for community health improvement at John Muir Health. Last but not least, we have Henry Loubet, CEO of Bohemia Health, who will be providing closing remarks for our panel. Henry is the former Western Region CEO of United Healthcare, where he was responsible for 1.6 million members across 10 Western states. Prior to that, he was the president of HealthNet, where he led plan growth to 750,000 members and $1 billion in revenue. Before we get started, I'd like to invite our audience to place any questions you may have during our panel discussion into the Q&A box. We will make sure to leave time at the end for your questions and responses from the panel. As you can see, we have an amazing panel of experts here with us tonight. So let's get this conversation started. Well, let's talk about this and virtual trends. So telehealth and virtual health usage has dramatically accelerated during 2020 because of COVID. Health systems, hospitals, and community health centers across the nation have transformed their systems to adapt and implement virtual healthcare, while digital health companies have taken over the market of primary healthcare. So to our panelists, where do you see the landscape of virtual health going in the next 3 to 5 years? Dilip, would you like to get us started?
Sure. Thank you, Katherine, and thank you for inviting me to the panel. Hi to all the folks on the panel and also in the audience. And this is really kind of the timely topic. As many of you know, COVID has really been a disruptor as far as digital health technologies are concerned, and really has brought many of the contradictions in our health system, particularly in relation to access, to the fore. Just for the audience, to give them an example of how rapid the adoption of digital health technologies has been. At USC, where I led the efforts around telemedicine and digital health, prior to COVID, we were doing about 20 to 30 telemedicine visits across the health system. In March, as COVID sort of hit, we jumped to about 9,000. And in June, we were doing about 11,000 visits per month. So think of that, a scaling up from 30 visits a month to 11,000. What has really come out of it, and I think some of the experiences that we've seen, both in studies in my previous place of work, USC, some of the work we've done at Alteus, and a lot of the information that is coming out from experiences in health systems across the country, is that both providers and patients, have really come to appreciate the value of telemedicine in clinical care delivery. And so I would say that, this was forced upon us. You have no idea how many people I begged to use this technology before COVID. And, I used to get the skeptical eye. And, since they've had practical day-to-day experience connecting with their patients in the home, there is no question that, there's no going back. So the question, I think, coming back to what you've asked, where does it go? Where would it go in the next 6 months, and where would it go in the next 1 to 3 years? I think across all health systems, since that initial peak in usage, we're all beginning to see a drop down, which is expected because patients are going back into the clinic, right? And so the future is clearly going to be a mixture of in-person visits and telemedicine visits. The sort of number that is kind of floated around is that probably once we reach a steady state, roughly about 25% to a third of the patients will continue to be seen through telemedicine and the rest in person. And obviously some of that's going to vary by, geographic access, specialty, et cetera. But I think you could probably take that as a ballpark. But I think what telemedicine has done is it's really opened the door to many other technologies. And so in many ways, telemedicine, that is just straightforward video calling, has really opened what I would like to call the broader field of telehealth or telemedicine. So patient apps, right? Patient engagement, your ability to make an appointment online, your ability to virtually register so that when you go to the provider's office, you're not having to sit with a clipboard for 10 minutes kind of filling in. If your provider's office is running late, the ability for them to message you and say, hey, Mrs. Jones, we're running an hour late. Here's a coupon for Starbucks. Why don't you go and get a cup of coffee for Starbucks? And I think that's the future we're seeing in the next 1 to 3 years, that much of what I would like to call the patient experience is going to change. The provider connection with the patient is going to change. And some aspects of care delivery, for example, the ability to go into the patient's home to kind of see what resources the patient has. Take an example of the vulnerable populations that we're talking about today. If I have an elderly patient today, I have no idea what their home circumstances are. I have no idea if they have a safe cupboard where they can keep their medication. I don't know whether they have support at home or do they have to climb a staircase every day. These are the kinds of evaluations that we're going to be able to do going forward with telemedicine. And then the next sort of big jump would be the ability to monitor patients at home for not just between provider and patients, but even within the extended living situation. So if you have an elderly dad that's living in Phoenix and you're living in Los Angeles, you'll be able to keep an eye on this, on your dad. You'll be able to see what messages are coming for your dad from the physician, help him with his appointments, look and see whether he's walked or not walked. And I think that's sort of the door and acceptance that COVID has really opened through compressing that timeline.
That's great. And and super exciting. I would love to see some of that come to the forefront earlier rather than, sooner rather than later. Diana, do you have, what's your perspective from the vantage of Kaiser Permanente?
Yes, thank you. And first off, thanks for having me. I'm really excited to be here. I've really long admired Asian Health Services and the work they do. And so thank you for that work, and really honored to be speaking amongst some esteemed physicians. So I think many of you are familiar with Kaiser Permanente as an integrated health delivery system. And like many health systems, we've been on a telehealth journey since the 90s. And it wasn't until the pandemic hit that we really saw the explosion in telehealth. And some figures to share with you. It makes up about 80% of our ambulatory care during peak moments of the pandemic. We saw an 100% increase in our phone visits from 2019. We saw a 4,000% increase in the use of video. And that actually the use of video is continuing to persist. And it's been something that Kaiser has long been challenged by, is kind of getting the uptake in the video, but we're seeing really great use of video at this point. Beyond the use of kind of standard telehealth, video, phone visits, there's a few interesting areas that I'm really excited to see what happens in terms of the virtual care space that Kaiser is beginning to do more in. The first was already mentioned in terms of remote patient monitoring. Like was mentioned, this allows you to monitor patients outside the clinical setting on key vital signs. And I think that's going to be really important to supplement telehealth visits, is also having that virtual monitoring. I was on a telehealth visit the other day and they asked me what my blood pressure was. And I was like, I don't know, maybe if you could take it, that would be great. I gave them a guess. I don't know how accurate that was, but it's just an example. It's going to need to supplement a lot of the telehealth visits. We are also beginning to experiment, I know many healthcare providers are, with artificial intelligence-based systems. We're using something called a chatbot, which we really implemented very quickly after COVID hit, to help assist in assessing patient symptoms around COVID. So it uses natural language processing and artificial intelligence to essentially evaluate COVID symptoms and provide guidance on next steps. And I think we're going to see a lot more of that for kind of simple, routine questions, obviously not for complex care, but I think you'll see patients being able to access more tools like that. What really excites me about this explosion of telehealth is its ability to address health equity by expanding access to care for more patients. Many people, particularly those that are low income and face barriers to care, have to take time off of work, have to find childcare, care for their elderly parents, take public transit, or even travel, very long distances to access care. Virtual care has the opportunity to nearly eliminate that if we're able to address their barriers and accessing it. I've seen some really exciting data in the community as well as at Kaiser that virtual care visit no-show rates for behavioral health have been virtually eliminated. That means countless more people are taking advantage of mental health and wellness support, which is huge when you have like large no-show rates and such. So that's that which really excites me. And then the last thing I'll say, and I think there's a lot that we can do more in this space, is around innovative strategies to address the social health of our patients, which is really important for low-income vulnerable populations. Public health has long embraced that someone's health is dictated not just by the care they receive, but the environments they live in. So their home, their community, and the social factors that color their lives. Like, do you have access to healthy food? Do you experience systemic racism? And, systemic racism is obviously a big thing to take on, and, everyone is doing their part. But Kaiser is starting to do more to look at these social factors and using technology and innovation as a piece of that. An example I'll give is with what we call our CalFresh texting campaign. Many of our members face food insecurity, particularly during the pandemic when people have lost their jobs and don't have money to put food on their table for their families. So we started a texting campaign to support them in enrolling in the Supplemental Nutrition Assistance Program, which many know as food stamps. To date, we've reached out to 2.2 million members across all of our markets and have helped in California alone 64,000 patients get on CalFresh, which is the food stamps program. And that's just a text. I mean, I don't even know if I qualify that as technology anymore. That's just basic, right? But what you can do with texting, I think, is really important in these communities. We're also doing more in the social health space around helping our patients get connected to social services supports. We partnered with a technology startup called Unite Us to develop networks of social service providers that our care providers can refer our patients to help meet their social needs. So we can now make a direct referral to a food bank from our EHR that essentially gets them connected to potentially get access to food. And then we're going to get that data back in the health record. And it's going to say, look, we made this connection to food. So we're really taking care of the whole person. And so I think that's just the beginning. I'm really excited about the social health stuff. You know, the AI is obviously very exciting and sexy in some points, but I think that's just the start.
Well, I love the fact that you're already seeing changes in outcomes and improvements in outcomes. And I mean, the no-show rate is quite phenomenal. So, excuse me for a second, I'm sorry. Vik, maybe can you tell us what trends you're seeing, especially as it applies to multicultural populations and the application of technology?
Yeah, absolutely. And again, I'll echo Diana's sentiments. Thank you so much for having me in a forum like this. Very much respect the work that Asian Health Services does in the community. At Consejo Sano, which means healthy advice in Spanish, by the way, we think about patient engagement in terms of culture. And we define culture as the attitudes, values, traditions, beliefs, all of the inputs that guide your decision-making, specifically in healthcare. And so when we think about these cultural determinants of health, and then we overlay it with technology that is geared toward understanding what your culture is, how you identify, how you choose to interact with the system, I would take the stance that yes, text messaging alone may not be a new technology, but the beautiful part about these native capabilities of smartphones is that they're convenient, they don't require a login and a password and so forth. And when a patient opts in or a member opts in to using these technologies, there can be a lot of technological science behind the scenes guiding that content. And so to your point or question rather about multicultural populations, Consejo Sano works with about 90% of our members and patients are on Medicaid. Medi-Cal here in California. And the preponderance of the work we do, if you think about California, 81% of the Medi-Cal program is diverse, is multicultural. And so there's a large need and an imperative to build technology that is going to understand the culture of the members that we're trying to serve, and then make it convenient for them to access care. And so when I think about the trends in multicultural care going forward and technology as it relates to that, they're, aside from access, right? Aside from just getting the tool in front of a member to be able to access care, there are so many other technologies that will allow us to do better diagnosis from a distance. So for example, today I saw an article posted on LinkedIn from a gastroenterologist about a pilot being done between Medtronic and Amazon that will actually allow pill endoscopy to be done from the home setting. And given that recommendations for colon cancer screening are moving younger and into the mid-40s, these are distributable technologies that can really, if delivered with the right culturally sensitive, culturally relevant message, can really drive detection of cancer and then have a downstream effect naturally of being able to lower overall cost of care, to improve quality of life, and all the benefits that we can imagine would go with advances in technology. And so aside from fit kit testing in the home and coordinating through text messaging in a culturally relevant way, or which also for colorectal cancer screening, for those who may not be familiar with the fit kit, aside from that option, we can do more advanced things now with technology in due time. And even the basics, to Diana's point about the no-show rates, it's phenomenal to watch. Consejo Sano scheduled approximately 50,000 telemedicine appointments in the immediate period right after COVID. Patients were scared to go into their primary care settings. Our society was scared. Many of us remain scared because of what's going on. And when we can find ways to deliver care, and we can drive the adoption curve forward for some of these technological capabilities, we can really make some lasting change in how people view the ability to receive the care they need. And so I really like the mental health example, because in that case with 50% of counties not having a psychiatrist at all. And when I think about the multicultural aspect of behavioral health care, 6% of psychologists are diverse. Approximately 20% of psychiatrists are diverse. 12% of social workers are diverse. These are national statistics. It boggles my mind that when we are talking about in California, communities that are 81% diverse, and we really don't have necessarily the level of diversity in our provider network, there's an opportunity for technology to bridge the gap and to help make that care not just accessible, but relatable and valued and appreciated by those who need it most. So I do see some of these trends in multicultural care, in distributed diagnostic modalities, in making the right kind of care at the right time accessible, absolutely a part of the equation in the near future. So I'm very encouraged and inspired by what's going on right now.
Well, you've got me inspired, thinking about bridging, cultural gaps, and then, as Diana and Dilip mentioned, the adoption that then leads to the change, right? So that it seems like it doesn't take a lot, but the fact is maybe 2020 and COVID has forced us over the hump of actually adopting and trying this out so that we can get to better outcomes. So, now that we talked about the cultural piece, let's move over to the barriers to technology. So when we think about tackling social, economic barriers, digital divide, health equity issues, I mean, these are significant challenges, especially in Medicaid populations. And among underserved populations, a key challenge is patients' technology, their literacy, their access to technology, their adoption, as we were just talking about, and even lack of internet, broadband, or device access. And going back to Dr. Lee's earlier example, in particular, older populations may have issues, not just with hearing or vision, but language and adoption, put it all together. So, to better serve these populations and to, bring the benefits of technology, what are some of the use cases that you guys have seen that worked well, and what didn't, and why do you think it was successful or not? Diane, why don't we start with you?
Great. Yeah. So a little known fact, I think some people do know this, is Kaiser has over 1 million Medicaid members nationally. Many, like we've talked about, of these folks are experiencing challenges in accessing telehealth, including broadband access, don't have the devices, and experience digital literacy issues. So I think it's really important, while we are moving towards addressing these issues, that we continue to give patients choice in how they access care. Not everyone wants to do a video visit. We need to be able to keep phone and in-person available as an option for those who don't have good access to an internet connection or a consistent data plan. Ultimately, we're talking about the value of telehealth, which I truly believe in, but until we get there, and I'm confident we will, get there and we'll get people access to the tools they need to do this, we need to continue to have choice. Because frankly, some people don't want to use it, and it's going to be hard to overcome that barrier in the long run. Some strategies that I'm excited about that we are working on is, in particular to our Medicaid population here at Kaiser Permanente, we're doing a lot of outreach to get them enrolled in our patient portal. That's a key way to not only access your video visits, but to message your patient. And so that that type of communication, making sure it's in different languages, make sure that it's culturally appropriate in terms of how we communicate and do that outreach. We have some work going on. So Kaiser Permanente is not just a care delivery organization, we're also a health plan. So as a health plan, we're reaching out to our Medicaid members specifically to help them enroll in the federal Lifeline program. If you guys aren't familiar with the Lifeline program, it's essentially a subsidy for getting you free smartphone if you meet income qualifications. So there really shouldn't be a barrier. I mean, it's got the best data plan in the world, but there are options for low-income communities to get access to, say, a smartphone with a data plan. So we're doing outreach to connect people to that Lifeline program, and then really continually educating patients on virtual care and its use. Some of the stuff that I often talk about is the really not super, exciting stuff around workflows. Like, we need to make sure if you have a video visit, you have a good video visit. So in terms of, if you're able to get on, you get roomed virtually. We call it virtual rooming with a medical assistant, and they're there to help you. So they're there to help make sure your sound's working, your video's working. So we're doing a lot with workflows. It's really, not that exciting to ensure that people feel comfortable using it. I think, we've seen the value of virtual care in our organization, and we know there's still a ton of work to do to ensure that we're addressing broadband and device and literacy. But to that end, our goal is we really do have a goal of supporting it, not just within our own system, but outside within the community. Back when the pandemic first hit, we decided that we wanted to invest in supporting safety net health organizations like community health centers to be on this virtual care journey with Kaiser Permanente. So we launched a program that's providing funding and technical assistance to these organizations to design and implement virtual care solutions. For example, we're going to be supporting health centers and homeless healthcare providers with training and technical assistance on topics such as how do you engage your homeless health patients with virtual care? How do you use team-based care to manage chronic conditions virtually? What do you need to do to get a remote patient monitoring program into place? And then what's really key to this is it needs to be reimbursed. If we are not paying for telehealth, it's not going to happen. And that's really key when it comes to the larger healthcare community, especially in particular for community health centers.
Great, thank you. I thought your comments there, especially on the virtual patient experience, is super key, right? We throw technology at the problem, but if it doesn't work or we're not, doing it right, it won't be taken up. Vik, do you want to talk a little bit about your experience and use cases that you've seen that worked or didn't work in terms of access to technology?
Yeah, sure. And actually what you both were just talking about couldn't have been a better segue, because the point of making sure that the technology works is there's a role for culturally relevant IT support, right? If we think about patient engagement in the world that I live in, a lot of our efforts, for example, a use case with a large Midwestern health plan and culturally diverse seniors involves the delivery of an iPad and then connecting with that individual, that senior, over the phone to walk them through. It's already configured, but even turning it on and pressing the right buttons and doing a few initial setup at the sort of point of care, if you will, a lot of that just takes a culturally relevant engagement and accelerates that adoption curve, like we were talking about earlier. So that's a use case that we've experienced very recently through this pandemic, because if we are going to empower culturally diverse, lower income individuals who need to access care but are afraid to do so in the traditional settings, or those traditional settings have not been accessible to them for one reason or another, then we need to find innovative ways to get technology in their hands that works, that they feel comfortable using. And then we can use it for a variety of reasons, right? We can address loneliness in the home. We can use that device for multiple members of the family and think about householding. How do you build trust with a family? It's about bringing a tool into the household that allows you to interact with everyone in that household who may need care and who opts in, who chooses to access care in that pathway. So these are just a couple of the use cases that come to mind, but all of it comes back to building trust and finding ways to connect with individuals and provide the resources that they need to be able to really take charge of their care.
Yeah, and your point about, well, I took away that you shouldn't assume, right, that certain people are not willing to accept technology. Maybe the technology is, too complicated sometimes, or we just need to, the whole idea of just walking them through this is I don't know, profound, I guess. So Dilip, any thoughts also in your experience of what you've seen when you've rolled out digital technologies to these populations?
Yeah, no, sure, Catherine. And I think much of what Diana and Vik have said has been our experience as well. But probably what I like to do is take the audience to think this sort of in a different context, right? So if you really think about where healthcare currently is, that's where the rest of the business world was in 2008. If you look at our healthcare just globally in the United States, we spend on an average somewhere around about $3.7 trillion a year. It's been estimated that 18% of 18 cents in every dollar that we spend is wasted. We're not even talking about productivity gains, in other words, providing care more efficiently and better and saving money. We're just talking about wastage in the system. And when that is translated, that's translated into $640 billion a year. And it's been estimated that about half of that amount, so roughly about $340 billion, because of inefficiencies in how we deliver care. So when you ask yourself the question, what are the inefficiencies or how do we deliver care today? If you look at our care delivery system in medicine, it is still largely analog compared to almost every other industry that's out there, right? So let's take an example. When you open up, your laptop and you open up PowerPoint, you're not thinking of PowerPoint as a connected internet application, because it's really an application through which you're carrying out your most immediate task, right? But when you really think about what PowerPoint is today, it is an internet connected application, because 5 people in 5 different laptops can connect into a single PowerPoint and work on those slides. So today we're talking about digital health as if it's a completely different modality from how we deliver care. And that's kind of how we thought of the internet in 2009, right? That I'm going onto the internet, but everything else that I did was done analog. I'm going to the bank. You never really thought that just logging into your Wells Fargo account or Bank of America account and transferring money is doing banking. In 2008, you went to the bank. And what has happened since then is that as the connectivity has sort of permeated through every aspect of business or banking, today the tasks that we normally carried out in the bank, we carry out through multiple devices or in the bank. It's kind of a seamless process. And so, so when you think of it from that perspective, we're talking about telemedicine today, but my prediction is that in 5 or 10 years, as this technology becomes more and more mainstream, as the delivery of care becomes truly connected, today it's all done sort of, on a per click basis. You're going to the doctor's office, the doctor's calling you, I'm calling another doctor. It's all just individual, isolated pieces of activity rather than a connected whole. As we start thinking of that, we are not going to talk about telemedicine versus an in-person visit, or it's going to be a continuum of delivery of care. And really, then what we should ask ourselves, the broader question is that what are the barriers to that, right? And the barriers to that, first is the way that medicine has sort of evolved, particularly with EMRs, is that we've created silos. So EMRs is sort of the first big silo where my EMR is different than the EMR where Vik works, which is different than Kaiser's EMR, which is different than my primary care physician's EMR. So interconnectivity and interoperability is one of the big barriers to going forward with all of this technology. And I think it's beginning to change as the federal government has kind of recognized that you've got to bring these walls down if you're going to improve the quality of health. But that's the first sort of big barrier. I think the second big barrier is really, as providers and as patients, we have, in the same way as we thought that if I needed to deposit that check, I had to go to the bank, or if I needed to transfer money, I had to go to the bank. That's the culture that we are in currently. And it is going to be changing of the culture where we see this continuum of tools that allow you access in different settings. So it's sort of that almost a cultural sea change of how you view medicine and the delivery of care as an individual, whether you're a provider or a patient. And then after that, I think we go through all of the issues that Vik and Diana have kind of talked about, the digital divide. We are still working with first generation technology, so that it doesn't always work for it. And I think what all of the folks on this panel have alluded is true. I'll give you one example. When I was at USC and we were rolling out the program, we make sure that we would call the patient ahead of time, test their mic, make sure they're able to download the link, test the link, they're able to connect, they're in the waiting room, they were able to connect. And then COVID hit, right? So we couldn't provide that personalized service. You could do it to 30 patients a month, but you can't really do it to 11,000 patients a month, particularly when you're going from 30 patients a month to 11,000 patients a month. And there was a lot of frustration with a lot of patients. And, one example of that was video, where a lot of the frustration was, And when we looked at our very early experience, 30% of video calls were switched to audio calls. And I'm sure, Diane and Vik, you've probably seen that data as well, because the way that the current technology provides that video connectivity going into the, clicking on the link, going into a waiting room, waiting for your doctor to connect. Sometimes nobody ever connects to you and you're kind of sitting in that waiting room. That whole process is kind of pretty cumbersome. But I think that's a matter of time. I think what we said at the beginning and what all of the panelists are saying, that the value of connectivity, if I can put it more broadly, and the need for us to change our care delivery models has become so apparent through the sort of COVID disruption that this is going to get better and better over time. And many of the issues that we're kind of talking about, they're going to be implicit, in addressing it. And when you look at, for example, the vulnerable patient population, you think about when internet first came about, it was the educated and probably the affluent that could afford at that time those exorbitant prices for for that 30 megabyte connection or whatever you had, right? And yet today, the cell phone has been probably the biggest disruptor of internet connectivity. More people access the internet today through their smartphone than they ever connected, with a landline. And I mean, large numbers of countries have been able to jump over the digital divide because of cell phone and sort of cellular technologies. So I think, these are all progressions as new technology comes in and sort of in the adoption and what I would like to say commoditization of the technology.
I appreciate the use case on the rollout of video and how we had to fall back. But to your point, I think that it still has promise, and I think we just have to keep improving and making it easier. So let's pivot for a moment so we just talked about technology barriers. Let's talk about language barriers. So another top issue, I think, Vik, you mentioned this within underserved populations, is the language barrier. And, for example, I think as Dr. Lee mentioned and Julia mentioned, AHS is serving a patient population that speaks 13 languages in addition to English. So can you talk about your thoughts about this issue and how addressing language barriers, how we get across this, especially in the virtual health world?
Yeah, absolutely. The beautiful part about technology is that we are able to understand very quickly, based on, in some cases from text messaging, based on syntax and based on name, based on so many other sort of inherent factors in the data, we can use technology to very quickly try to statistically anticipate what language is convenient for that patient to communicate with us in. And given that we don't often have a preferred language on file, sometimes our opportunity to interact with our patients in a culturally relevant, linguistically appropriate way is based on those first few interactions. And in some cases, that's all you have to be able to build trust. So to your point, I think a lot of the opportunity with technology to be more linguistically relevant in the communities we serve is to use that technology on the front end through predictive analytics to really bring to bear the right resources for that particular patient or member. And in some cases, that's hard to do in the clinic setting. You may schedule patients when your Vietnamese speaking advanced practice provider is available. However, that person may fall ill that day, and then we're resorting perhaps to a technology tool in the clinic, but no one can sometimes find that little iPad on a rolling device. Or if you can, I've actually had very good experiences using it at UCSF, but if you can, access it for one reason or another, it's still an awkward interaction. And the beautiful part about technology is that we have a few different ways to address this language gap, right? To address this culture gap that exists. One is, like I mentioned, understanding at the outset what is most likely needed in that conversation and being able to bring that to bear. The second is the ability to actually use a technology interface where we might be speaking different languages, but we're understanding each other. And that might be a little bit farther ahead in terms of the universal application of that technology, but it's really exciting to see what's being developed right now, right? There's a key role for that to be able to really augment the interactions that people can have with other people, both inside of healthcare and outside of it. And the question will be, progressive organizations like Asian Health Services might employ those technologies early on in the adoption curve, so that people can really have a chance to access care in the best way possible, and ultimately build that trust that allows that individual to feel loved and cared for, and to feel like they have a place to go where they're understood, right? And that's really what it's all about, because we cannot continue to rely on individual person-to-person exchanges to drive better quality outcomes. We have to think about it in terms of scalable, technologically driven ways. And some of these opportunities, whether it's a real-time translator that's helping to at least get some of the words right, that's a step up from where we are now, where sometimes you may send a message in English but not have any response. And so if you use technology, you can send that message in English because you don't know what the preferred language is. And then you can iterate based on, again, a variety of data elements that help you understand what languages are worth considering to at least make the person aware are available. And then, certainly as we move, sort of in terms of the acuity of care being delivered, there are a multitude of other technologies and options that can make sure that the portal that's being developed, or that the consent form that's being put in front of the patient, or that, the other meaningful interactions are really done in a linguistically relevant way. So I hope that provides a little bit of color to how we think about it at Consejo Sano.
I think that was, it's really impactful, because I think what I heard you say is that it's, you only have a few moments in that initial interaction, right, to build that trust, and the idea that technology can help interpret or be the mediator in the middle to make sure that you establish that trust rather than let it float away in those precious moments. Diana, any thoughts about you on things that you've seen about over methods of communication or overcoming language or cultural barriers?
Yeah, I don't want to downplay the need for competent healthcare providers that speak the patient's language, right? Interpreters are a great solution, and we absolutely have to use them. But more important is investing in a pipeline of workforce that has the cultural skills as well as the language skills to build that trust with their patients. So I want to say that first and foremost, the Spanish you picked up in Cabo is not going to cut it in the office. So we really need to ensure that we're certifying our bilingual providers, which is something that Kaiser does. So beyond that, though, Kaiser's done a lot of work in ensuring, again, I keep going back to workflows, because it really is just ensuring that this care is delivered in a way that is seamless. Ensuring that the interpreters, we've done a lot of work to ensure interpreter services is really very seamless with a video visit or with a phone visit. So working with all of our vendors, all of the things to make sure that they can plug in very easily. And I think video is a great use of interpreter. There's so much in terms of visual cues that you miss with a phone interpreter, where you lose a lot of that, which I think is really important for building that trust. We've even done a lot of specific work on making sure the video screen is arranged in the right way, so for a patient who speaks American Sign Language, that they can do the synchronous, the simultaneous interpretation in a way that everyone can see each other the right way. So it's really just these little nuances that help build a better experience for patients who who use some type of interpreter.
Thank you. I think, just thinking about the different populations that you're serving and the needs of those populations in the adoption of technology, again, one size doesn't fit all, is quite interesting. So we only have a few minutes left. Let me move to our last question here about targeting innovation to our highest need populations. So how do we ensure that all of this innovation we target towards these high need problems, driving the future of health for our aging populations, our most vulnerable populations? Dilip, what are your thoughts on that?
So since we don't have much time, I'll just give a few bullets. I would say that it needs to start at the point of innovation. We need to have folks that are involved in innovation that are diverse in their cultural background, that understand some of the problems in vulnerable populations across all settings, whether it's a patient that has a hearing disorder, whether it's a patient that comes from a poor socioeconomic background, is homeless, or whether it's a patient that comes from an underrepresented minority group. I think that today is probably one of the biggest challenges in putting technology together. And you've seen a lot of data come through on AI modeling. There was a lot of controversy recently regarding Optum Platforms analytics, which didn't take into account some of these issues. So for me, I think it's got to start at the top in making sure that at the point of innovation, companies are very, very sensitive to these needs.
Thank you. And Diana, any thoughts about this one?
Yeah, I think, to build off his point, we can't be afraid to venture into this, and take steps. I'm a big fan of process improvement and human-centered design, which is all about looking at your data, testing it, trying again, looking at your data, testing it, trying it again. And we really have to take that approach to developing this innovation so that we're not overwhelmed by, the prospect of what is it really going to take to get all of our patients to do video visits, and really involving the care team in those decisions. It can't obviously be kind of top-down dictated, as well as the patient. It really needs to be centered on the patient. They need to be a part of the process. They need to be a part of the solution.
Thank you. So, what I take away from both of you is, we need diversity at the point of innovation from where we think about it. But then when we, bring in that factor of human-centered design, right, in terms of thinking about it from the perspective, not just of the diverse set of patients, but also the provider's perspective, and ensuring that we are creating that interaction that works for everybody. So thank you, guys. Thank you to our panelists, Vik, Diana, Dilip, for a lively and very insightful discussion. We do have time for Q&A, so I've seen, so we'll get to that in a moment. But what I'd like to do first is introduce Henry Loubet to provide some closing remarks.
Hi, thanks so much, Diana. First of all, great panel. I'm sure everyone learned a lot from our experienced panelists and such. As someone who's had a long background in managed care, United Healthcare, HealthNet, Valley Health Plan in Santa Clara County when I moved out here, I find today the most exciting time since I've been in healthcare, which has been many years, because there's so much change taking place. I know that's stated a lot. But the fact is, we hear things like Chief Innovation Officer, Chief Strategy Officer, Chief People Officer. Those titles in healthcare never existed in the early days as it related to health plans. We have health plans that heretofore only serve commercial populations, the big health plans, now serving Medi-Cal and Medicaid, Medicare, Medicare Advantage, dual eligibles, and areas, exchanges, areas that were never thought of before for health plans to provide. And even when I was working in health plans, that wasn't an area that you went to. It's really exciting to me to see that taking place now. Same thing on the provider delivery side, right here in Alameda County. We have someone like Hill Physicians, led by David Joyner, a great executive. Hill only provided capitated HMO services in the past. They never provided services to Medi-Cal, services to PPO patients, services to Medicare Advantage patients, and now they do that. To me, it's just excellent, as well as seeing all the things that health plans are doing as well. And finally, relative to innovation, we're seeing a whole new field within healthcare that I think all of you here, especially as I've talked to Julie at Asian Health Services, oftentimes get left behind and need to be out front there. And these are the areas now at Bohemia Health that I work on in health technology. But we have new areas like digital therapeutics and pharmacy. Care navigation on the employer side, companies like Payer Therapeutics and Right Way Health. Chronic care right in our own backyard with Omada Health and Livongo. High performance networks also in San Francisco like VIN. telehealth, like we've talked about, and is the most prominent, but not to discredit all health, virtual care and telehealth is the most important change that's affecting us, but most likely in this space. But relative to all the new companies that have emerged literally in the last 5 to 10 years, and hadn't been part of the landscape before. So I challenge all of you, especially the audience, to be able to reach out to these companies. As I work with these companies, I push hard for diversity as it relates to FQHCs and other care providers, and Consejo Sano does a great job on advocating for that as well. So but I think, you have to push and advocate, and you have to get folks like me to advocate for you. And that's a lot of what I try to do in my tenure with Bohemia Health. So again, it's an exciting time in healthcare. Just today, for example, we saw the lowest increase year over year in healthcare costs in the Mercer study, 1.9%. Again, a lot of that because of delayed care under COVID, but some of that I think because of improvements in health technology and healthcare delivery. So again, those are just some thoughts that I have relative to the opportunities that now exist in what I call the new marketplace. So thank you, Dinah. And Catherine, I'm sorry.
Thanks, Henry. I guess it's pretty, I don't know. I personally am quite excited by the possibilities of what we've got going on. And, maybe COVID, for all its tragedy, it's perhaps shedding, this is the golden silver lining for 2020 and the promise of that technology. So let me go to a couple of questions that we've got from the audience. So we've talked a lot about the promise of telehealth and virtual health. Does somebody want to talk about what are the key risks of this and how should we address it accordingly?
I can kick things off, sure. When I think about one of the risks, privacy and the invasion of one's privacy, now that we are bringing these technologies into the home, there are legitimate concerns about being hacked. Naturally, we're transacting very private, very personal information, and that can, ultimately be used, potentially in negative ways. And so I think we sometimes discount that because the greater good of providing access to care seems to be appropriate. But I think privacy is a risk that we ought to address through the appropriate encryption standards, through the appropriate controls and mechanisms that are in place to keep information in the right hands and out of the wrong ones, and make sure that the patient experience is balanced against any potential risk of privacy or intrusion.
Great, thank you. Anyone else? Okay, go ahead. Yes, Dilip.
Yeah, and I think there are probably a number of risks that have not been thought through with respect to rollout. And a couple of those would be, as more and more platforms come out into clinical practice, and Henry talked about some of them, you could see that we may continue to balkanize delivery of healthcare. Today, we just have silos with EMRs. But now, if you've got 5 different organizations using 5 different, say, remote home monitoring platforms or telemedicine platforms, and none of these kind of talk to each other, and all of the data is segregated in these different proprietary platforms, you can see how that could become problematic as you're trying to get a longitudinal data set on which you can do, analytics and things like that. That's sort of, in my mind, one big question mark, and some of that is going to be addressed, obviously, how that evolves and whether we get more dominant multi-function platforms rather than what we have today, which is an app for everything. The second big area of risk here also is that the pendulum may swing too much towards virtual care, and much of that patient provider, that personal experience that you're used to with that patient coming in your office and with whom you've developed a lifelong longitudinal relationship, that some of those aspects of the relationship may start, changing as these technologies become more mainstream in terms of how patients access care.
Yeah, and I think, I think about the example that you provided earlier in terms of financial services, being a little bit further ahead of where we are. And so I think we need to think about, to your point, privacy, how do we integrate all of this information, but also in a secure manner. Really quite interesting.
I would say, and private, I just want to call out the privacy thing spoke to me because I thought, Vik, you were going in one direction and you took it in a different direction, but like privacy in your home, you get healthcare in a home typically, and we need to take people's whole situations into account. And if you're in a situation where it's not safe for you to get your healthcare in the home, that's one thing I think we always have to be thinking about.
I like that, yeah.
So actually, I think, Diana, I may pose this next question to you. So we, as we think about these new technologies, I think you mentioned it earlier about reimbursement and as health plans and providers move towards value-based payment models, how do we incentivize good medicine or limit abuse? I think, Dilip, you even mentioned, a little bit too much swinging the pendulum one way in order to reward positive health outcomes. How do we, design the right system of incentives, if you will?
Yeah, and I think coming from Kaiser Permanente, if folks know how we're structured, we are structured in a way where those incentives are aligned, right? We are a health plan, we are a hospital, and we are a medical group. And so it works for Kaiser to provide a lot of telehealth because all of the incentives are aligned for us in terms of how our payment structure works. So I think that there's a lot of discussion on how do we take the typical healthcare world where all of these are a little bit separate and create payment structures so that we incentivize high quality care. And I think moving to payment modernization where we are helping organizations, we're giving them a capitated rate, if you will, for all their care is only going to continue to help drive the innovation, to help drive our providers really kind of leaning into this telehealth work. And one of the things that I've been thinking and working a lot on is around reimbursement for telehealth services within the community health center world, so within FQHCs. And that's something that is only temporary right now because of the public health emergency, but there's a lot of uncertainty on when that public health emergency lifts, how are we going to pay for this? And instead of talking about paying for telehealth and the immediacy, we need to be talking about how to, move towards sustainable payment monetization where we're paying health centers in a different way. So just a few thoughts, but I'd love to hear others' thoughts on it because Kaiser, it's frankly a little bit easier just because of the way we're structured for all of this to work out.
Henry, any thoughts based on things that you've seen across many different states?
No, I think value-based care and the component parts thereof, of course, you've seen it once, people define it in different ways. But as Diana's discussing, Kaiser, she says Kaiser's fortunate. Kaiser's not fortunate. They're the ones that created the model. So, and deserve a lot of credit, both for being such an advocate relative to health insurance and providing insurance to workers and as well as the type of aligned model that Diana describes. So, so I think, I think all of us here have discussed the fact of the opportunities that are out there. And again, I have to admit, I never thought that I would see mainstream healthcare, it's hospitals, medical groups, health plans wanting to serve this diversity of populations that they're now serving. And then other health plans like Oscar and some others have emerged. And then in all the county, Alameda Health Alliance, we're just seeing a whole number of things over the last 10 or 15 years that gives Katherine a lot to consult about. And there's just a ton of opportunities out there for all of us, I think, that we're seeing. And this whole, as I think it might have been Dilip said, the digital divide, again, terms that weren't in the lexicon when I started in health plans, all of a sudden dominate the lexicon. So I just think it's great to see this. I'm fortunate. I actually, in spite of my appearance, I speak fluent Spanish, and my my son's actually half Asian. So I've had the opportunity, I've worked in Robert Wood Johnson community health centers in my past. So to me, just to see this happen is just exciting. And we have such great leaders here on this panel and others.
Thank you. Vik, I may start this question with you from the audience. What advice do you have for upcoming health professionals to push for culturally and linguistically appropriate care, and how can they get involved in this work?
Sure. There are so many ways to deliver that care, even if you yourself maybe don't have that language skill set. But advocacy is probably one of the biggest ways. Advocacy within your organizations, advocacy within your communities. Find ways to represent a set of values to those around you that involves delivering culturally appropriate care. Find ways to influence the recruitment processes of your organizations by involving yourself in interviewing, by networking with people and heads of departments who are hiring, but be involved in the process, be an advocate to channel that energy around wanting to bring in the right kind of talent to the organization that will allow it to move forward with its goals around health equity and so on. The other way is to join organizations like Consejo Sano. We are doing a lot of great work, and you're welcome to come join us on this journey. We just raised another round of funding, and we're so proud to have wonderful partners as clients. Our contracts cover about 120 million Americans, so we really have sort of a lot of impact, and we'd love for you to join us. And that's just a silly way that I'll mention here, but in truth, find organizations that you appreciate and that sort of with the mission that you're aligned with, and really just sort of move toward those organizations. Right, the rest will work itself out.
Thank you. Dilip, I may send this question towards you. I think you started alluding to it earlier. So are there any technological trends or innovations that we're currently seeing in other industries that you think that we should be bringing over to healthcare now or in the future?
Yeah, no, absolutely. Technology is always sort of cross-seeding across, all verticals, right? But some of the areas, I think one that Diana talked about is artificial intelligence. We are in very, very early phase of AI in healthcare, but you could see that in the next 1 to 10 years, particularly as AI technology, to build AI models is becoming more of a commodity, and moving out of sort of highly specialized academic labs and very, very expensive sort of commercial rollouts. Today, through something like OpenAI and a number of other companies, you can take AI and start building models around it. So as AI becomes, as the cost of AI applications drop, to build applications drop, we can see that becoming increasingly in the mainstream. And the other thing that is going to spur that is availability of large data sets now, which we didn't have, for example, in medicine. So your HIEs, for example, right? Your claims data set, now that EMRs are becoming more open, and then the tons and tons of data that we're going to collect once we start doing things like remote home monitoring, etc. So as we start getting all of these large data sets, the ability to convert information overload into smart data is going to become a critical factor, and we see that that's sort of one big trend. The other big trend in other industries is augmented reality. And I've seen some very, very interesting applications of augmented reality and immersive reality. So an example would be before you're going for surgery, particularly for children, is where through an immersive reality program, you can sort of almost experience what that pre-surgical visit is going to feel like, and sort of be guided through a little bit of what your surgery is going to be and what your post-surgical outcome is going to be. There are actually several studies that have now been published that have shown that taking a subset of patients and kind of providing them with the experience, their post-surgical cause is much easier in terms of number of parameters like pain management, length of hospital stay, etc. So without any question, I think augmented reality is going to be a huge thing. There was a recent study, and I think all of the panelists have sort of alluded to this, and that is, as we start going particularly to certain subset of patients that are vulnerable for various, in various categories, the written word, the ability to access information from something like an iPhone, which, requires, you need to have a good eyesight, you need to have good tactile ability to press those buttons. So if you've got, vision issues, or if you've got, say, chronic rheumatoid arthritis, I mean, there are a number of patients that would find those devices difficult to handle. So voice-based technologies, and you can see how Alexa and Google Voice has permeated many of the other industries. And now that Alexa is HIPAA compliant, we can see over the next 1 to 3 years a number of voice-based technologies coming into medicine and having applications in the elderly population, in the disabled population, etc. So that those are just some examples of technologies that are currently not very widespread in healthcare that I can see even in the 1 to 3 year time frame becoming more widespread.
So I think we have time for one more question. Diana, I may send this to you to comment, because I think it's more of a comment. So appreciate the contributions of technology and hoping that it will continue to support reducing the burden on the practicing clinician to minimize clicks, increase voice recognition and commands. Also to perhaps reduce the gaps in clinical healthcare workforce. Any thoughts about this? Because as I know you mentioned, the workflow, making sure that the workflow is actually supports increasing the efficiency of virtual care.
Yeah, not much I would add to this. I mean, I think this is a very insightful comment, and it can't not be undermined. Every time we do any type of change to anything within Kaiser Permanente, it's like, how many clicks, how many clicks, how many clicks, right? And so I think that is pervasive across the healthcare industry, and needs to be very thoughtful, and not just on the provider side, but on the patient side as well. So I wouldn't add anything other than that. Totally spot on, and totally agree that that needs to continue to be a focus, and providers need to speak up, and they certainly do within Kaiser Permanente, but I'm sure in other places they are as well, in terms of like making sure that it's as easy to use as possible.
Great. Well, I want to thank all of you, Dilip, Diana, Vik, Henry, for being on this panel with us, and really enjoy the conversation. So with that, I'm going to turn it back over to Julia.
Well, thank you so much, Katherine, and just want to thank our esteemed panelists today for really your wealth of insights and the conversation and dialogue today. Just really appreciate all of the different textures and layers that you have brought forward in terms of what we're thinking about in terms of your innovations and the shaping the future of healthcare. I mean, there's really so much that has occurred, and so we're just really grateful to your inspiring conversations. We've had comments here that people want to continue this discussion, and so really thank you again, and just want to thank our co-hosts once again, and please feel free. Asian Health Services, I know if you want to be in touch with the speakers, and if you want to be interested in learning more about Asian Health Services, please contact us. I'm going to put up a quick slide here. We really thank all of you for joining us today. So here's the contact information, and again, we will be in touch with you. We would love to continue this conversation, and thank you again for joining us this evening, and have a good night.